Good afternoon and welcome to the National Combined Grand Round on COVID-19 being hosted by the All India Institute of Medical Sciences. And this time we are basically having a topic on managing comorbidities with COVID-19. As we very well know that with COVID-19 there are a lot of comorbidities which not only lead to a poor prognosis as far as COVID is concerned in terms of morbidity and mortality, but these comorbidities themselves also sometimes get aggravated because of underlying COVID-19. And we will be having a case presentation of 3 related topics, which could be on diabetes, heart disease and mental illness in patients who had these illness and also had COVID-19. And after that, we'll have a general discussion on challenges of managing comorbidities with COVID-19. The first case that we'll have is basically on diabetes. I think it's very important because as we know that diabetes has emerged as one of the important comorbidities which can lead to a poor prognosis both in terms of morbidity and mortality, especially if the diabetes is not well controlled in COVID-19. It's been well said that it's like a collision of 2 pandemics, the COVID-19 pandemic and the diabetes pandemic, that has really led to a worse outcome in these patients. We also know that this is a bidirectional flow as far as diabetes and COVID-19 is concerned. In individuals who have diabetes, they have more severe COVID-19 infection, but also it's been shown that COVID-19 leads to worsening of their metabolic parameters with hyperglycemia and even diabetic ketoacidosis. There's also some data which suggests that it may aggravate or lead to the development of type 1 diabetes also. The challenge is, of course, that we all know that anyone who has diabetes, infection control becomes a big issue. And at that point in time, how do we actually have good glycemic control? If you are very aggressive, we realize that hypoglycemia itself can lead to higher morbidity. At the same time, we don't want to have a very high blood sugar because that can be associated with progression of the infection. So to discuss all of this, we have Dr. Yashdeep Gupta, Associate Professor in the Department of Endocrinology, who will be presenting a case of diabetes and will also briefly touch upon this topic as far as diabetes as a comorbidity with COVID-19 is concerned. So I'll hand over the mic and the presentation to Dr. Yashdeep Gupta.
Thank you, sir. Good afternoon, everyone. My presentation will focus on diagnosis and the management of diabetes in patients with COVID. This is predominantly based on a document which we prepared in the Department of Endocrinology and Metabolism after multiple rounds of consultation with the stakeholders. And subsequently, this document has been adopted by the Ministry of Health and Family Welfare as their clinical guidance on the diabetes management. But before I move to this guidance, I would like to present the 2 case scenarios to sensitize the nuances of management of diabetes in COVID patients. So this is a first case, a 64-year-old gentleman who was well controlled on 3 oral glucose lowering agents and 20 units of basal insulin before he contracted COVID. After admission, he was found to have a high blood glucose level, and this required 2 changes in his management plan. The glimepiride was discontinued, and he was shifted from the basal insulin to a basal bolus insulin regimen, which comprised the 3 injections of regular insulin given for a prandial coverage before meals, and 1 shot of a basal insulin which could be intermediate for the long acting. This is a glucose log, and basically it depicts how an ideal glucose log should be maintained to be more informative. The second, the glucose monitoring has to be done in relation to meals. You will see that there is a before breakfast, before lunch, and a before dinner pre-meal blood glucose log, and there is a 2 hour after breakfast, 2 hour after lunch, and 2 hour after dinner value, which dictates the management of the patients in scenarios managed with the insulin regimen. And to be more effective in management, then the pre-meal and the post-meal values both have to be taken into account to dictate the required insulin changes. What 3 important messages I want to give through this log, that even with a patient with having a good glycemic control before admission, after contracting COVID can have a poor glycemic control. The early monitoring and an appropriate action with initiation and up titration of insulin as per requirement can achieve in early euglycemia. As you can see that the patient started having euglycemia on day 4 and day 5. The consequences of this good management plan can result in overall improved clinical status for the patient, and it also decreases the pressure on the hospital services in terms of requirement of ICU and a prolonged hospital stay. And it has been shown that diabetes with poor glycemic control has nearly 3 to 4 times mortality as compared to the non-diabetic patient. So it also improves the mortality for the patient. This is another case in which the patient, again, a 55-year-old male, controlled on 1 gram of metformin before admission, got admitted with COVID, and on day 3, due to his primary underlying illness, he was initiated on IV steroid, 96 milligram per day, which was given for a 1 week, and subsequently he was switched to oral glucocorticoids, 32, 24, and 16. These are like tapered over 5 days each, and nearly after receiving 4 weeks of the steroid, he was taken off these steroids. What you can see is that with the initiation of IV steroids, there was a steep incline in the requirement of insulin. The patient was practically on no insulin before admission, and with the initiation of steroid, the requirement went into 154, and this happens in a matter of days. It's like within 5 or 6 days, the requirement went to 154. And with this, you can see that the usual requirement of escalation was not 6 or 8 or 10 units per day, but it was like 20 to 30 units per day, which was required to achieve the euglycemia. But once the patient was tapered on the oral glucocorticoids, subsequently the requirement also matched and followed the graph of down titration of steroids, and so there was a down titration of insulin. Again, the requirement went dramatically down, and after 4 weeks, when the steroid was stopped, next day the patient was taken off insulin regimen, and he continued to have a good glycemic control on metformin 1 gram BD and sitagliptin 100 mg OD. So in this log, there is 2 important messages which I want to highlight. If you concentrate on a red part, the post-admission day 19, you can see that before that the patient was requiring 4 doses of regular insulin and 4 to 5 doses of regular insulin and 2 units of basal insulin. But on post-admission day 19, when his oral glucocorticoids was tapered to 24 milligram, the requirement of insulin went down, but simultaneously the number of injections also went down. Typically, what was a basal bolus regimens that So what you can see from this blood glucose law, that the patient which typically required 3 shots of regular insulin before meals and 2 shots of basal insulin, after the tapering of the glucocorticoids, he required 2 shots of regular insulin and 1 shot of basal insulin in the morning. So what was a typical basal bolus regimen? The patient was switched to the basal plus, in which you don't require to give the regular insulin before each meal. The second practical point that has to focus upon, there is a gross differences between the insulin requirement before lunch and before dinner. So once the patient is on oral glucocorticoids once a day and given typically in the morning, there is a peak in the after lunch and the before dinner glucose, and to control that part of the day for glycemia, the more requirement is of insulin required is in the before lunch as compared to the before breakfast. So the doses are higher in before lunch as compared to the before breakfast doses. So depending for providing the optimal management for the patients, we developed a guidance which was adopted by the ministry, and the purpose of developing this guidance was there were two main objectives. The foremost was that there is bidirectional association between the COVID severity and the hyperglycemia. With increase in COVID severity, the hyperglycemia worsens, and with the worsening of the hyperglycemia, the outcomes of COVID are bad. There is ample guidance on the primary management, on the management of the primary disease, but still there is a lack of guidance on the management of the comorbidities such as diabetes. So to overcome this deficiency, this document was prepared. The second purpose was that in the COVID care facilities, the expert care may not be available for each and every patient. So it was important to implement the core principles of management, but in a language which is simplified and can be understood by the practitioner working in the COVID care facilities. So this is the data from this slide suggests that the prevalence of undiagnosed diabetes is nearly equal to the prevalence of diabetes diagnosis, and both are high. But what is more important is that the mortality data means there is nearly 2-4 mortality in a group which remain undiagnosed as compared to in the group which has a known history of diabetes. The third point which is important from this slide is that there is a 10-fold increased mortality in patients who had a bad hyperglycemia as compared to the one who have a good hyperglycemia, defined as an average blood glucose less than 180 during the hospital stay. So there are two practical action points that comes out of this slides. One, if you want to decrease this mortality seen in the red bar, we have to be aggressive and diagnose for the undiagnosed diabetes and stress hyperglycemia. And after diagnosis, the second part that comes into action is that we have to aggressively manage the blood glucose to achieve near euglycemia so that the mortality in these patients and outcomes of these patients can be improved. So how we are going to approach to the patient who comes to the COVID facility? So once a patient lands up in the COVID care facility, the first and foremost part will be to go and ask for a history whether the patient has whether patient has previously known diabetes or not. Once you ask that, you will be able to detect 10% of the patients presenting in the COVID care facilities. And after that, the intensive blood glucose monitoring should be initiated, and depending upon the glucose levels, the appropriate action plan should be put into practice. If we don't do anything further, so we will be having 9 patients or 90% of the patients labeled as normal. But we should not stop that here, and we should further investigate these patients for the undiagnosed diabetes. And with this investigation, you can pick 10% additional with having underlying diabetes, but the status was not aware. And if you complete a set of investigation, to 10% can be detected to have a stress hyperglycemia. So means for every one patient of diabetes, there will be 2 additional patients of hyperglycemia which need to be detected and should not be missed. Because we have seen that the mortality in these 2 patients, or 20% of the patient, is even more as compared to the mortality in the patients with a known diabetes. So once realizing this importance of diagnosis, how we are going to approach these patients? Let me give you a pictorial picture. A patient who comes, for example, in a COVID care facility at 2:30 p.m. So at the time of admission, the one can do a random glucose by the capillary by a glucometer, which is easily available in COVID care facilities. And depending upon the value, for example, if it is grossly high, for example, 250 or 300 in the presence of symptoms, this suggests that patient is having underlying diabetes, and the appropriate action plan should be initiated at that point. But in case of borderline glucose status, for example, 180 or 200 milligram, in the absence of typical symptoms of hyperglycemia, we suggest that a patient should undergo a pre-meal and a 2-hour post-meal glucose value by glucometer with the first major meal. And if the values are suggestive of these above cutoffs, for example, pre-meal more than 140 and post-meal 180, it again suggests that patient may be having hyperglycemia, which could be stress or could be representative of undiagnosed diabetes. But we should not stop here. The next day, we should try and send a sample of fasting plasma glucose and A1C. The advantage of A1C is that we will be able to differentiate between the undiagnosed diabetes and stress hyperglycemia with this value. And in case of a patient is having already a diagnosed case of diabetes, it will give some indication of the previous control. And this should not be difficult because the routine blood sampling is being sent anyhow for these patients. What I typically presented in the last slide was a static evaluation of a patient in the initial 24 hours of admission. So hyperglycemia is a dynamic entity, the initial investigation may suggest that patient is not having any underlying or unknown diabetes or stress hyperglycemia at admission. But with severity of illness, it is well known that the patient can develop stress hyperglycemia. And there are high chances that patient with a moderate to severe COVID may require steroids in hospital. And with steroids, they can develop a drug-induced hyperglycemia. So it is a good clinical practice that this patient should be evaluated regularly with a glucometer or a venous plasma sample, again, which can be clubbed with the investigation data sent to the lab or can be done bedside by the glucometer, so that we can detect stress hyperglycemia early on and put into action an appropriate action plan. We also know by now that the patient with age greater than 50 with with hypertension or overweight or obesity or some other underlying comorbidities which can affect the outcomes in this patient, and diabetes can be associated with this condition. It is a good clinical practice point that this patient also underwent routine monitoring, say every 3 or 4 days with a glucometer value or a venous plasma value. So what about a patient of a diabetes who is on oral glucose lowering agents and presenting to the COVID care facilities? Whether we should continue, whether we should stop, which OHA has to be stopped and which can be continued. So if patient is having a mild COVID disease, there is no contraindication for continuation of drugs, and the patient is having mild hyperglycemia, the drugs can be continued. But the safer one to continue is a DPP-4 inhibitor, and out of that, from the economical perspective, vildagliptin and teneligliptin can be preferred. In general, there is advisory that the other drugs should be stopped, but in case there is no contraindication and one is wise enough to cautiously continue, the metformin and sulfonylurea can be continued. But again, it has to be keep into mind that once the insulin is initiated, sulfonylurea has to be stopped. And in case the patient is in HCQS, again, there is a high risk of hypoglycemia. And in such cases, sulfonylurea can be considered for stopping. There is clear-cut guidelines that due to the contraindication, SGLT2 inhibitors and pioglitazone should be stopped at admission. When we need to initiate the insulin therapy, in the case the patient is having moderate to severe COVID disease and is having moderate to severe hyperglycemia, or is having any contraindication to drugs, the oral glucose lowering agent should not be continued, and in such cases the insulin therapy should be initiated. We suggest that the patient can be put on the basal bolus insulin regimen, which means that 3 shots of regular insulin or a short rapid acting analogs, coupled with the 1 shot of basal insulin, which could be intermediate, or the analogs which could be a long acting. So this can be initiated in patients who have a pre-meal greater than 180 and post-meal greater than 250. But if you see that the blood glucose are grossly elevated, you can take initial decision of putting the patient straight forward to the insulin infusion. And if you don't do so and you want to try for the basal bolus, so one should keep a low threshold to start insulin infusion if one is not able to achieve the euglycemia in a desired time frame. So coming to the basal bolus regimen, when we initiate the basal bolus regimen, again it can be initiated in a dose of 0.4 units per kg per day. Again, this is a rough guidance which should work for most of the patients, but in case there is some underlying situation which can make patient prone to hypoglycemia, a lower dose can be started. On the converse, the higher dose is suitable for patient, for example, in obese patient or someone who is put on the steroid. So it can be divided equally into 25% each if it is a conventional insulin of regular plus NPH, 3 doses for a bolus, means given before meals, and 1 dose of intermediate acting insulin, basal insulin, which is given after dinner. So metformin and DPP-4 inhibitors can be continued, and obviously metformin with caution, and the other drugs should be stopped in these situations. And one should target a pre-meal of 100 to 140 milligram per deciliter and a post-meal of 141 to 180 milligram per deciliter, avoiding the hypoglycemia in such patients. This is a rough guidance. A detailed guidance can be obtained in one of our paper published, which has extensive examples to understand means how one can titrate. And this guidance is also available in the documents means put in the Ministry of Health and Family Welfare domain. So coming to the insulin infusion, these are some indication in which insulin infusion can be initiated. For example, uncontrolled hyperglycemia despite use of basal bolus, a critical ill patient like sepsis or septic shock, hyperglycemia in which the diet pattern is erratic, or in hyperglycemia emergencies like diabetic ketoacidosis. So there is some emergencies, means the patient needs an emergency service and the blood glucose levels are high. So insulin infusion is appropriate in such situations. The initiation is can be initiated at a low dose 0.05 to 0.1 unit. Again, this is a rough guidance, and the titration will depend upon the factors like what is a meal or diet pattern, The factors influencing the insulin sensitivity and resistance, for example, on glucocorticoids or the level of illness, the level of glucose to start with, what time of day, for example, the requirements are typically low at nocturnal time, diet status, and what is the target levels. And the patient can be switched to the basal bolus if these factors are satisfied, and the target blood glucose levels are achieved. Again, the details can be obtained in the detailed clinical guidance document that I referred initially. So coming to the last slide, what should be the discharge plan? Again, if the patient is on well-controlled initially and there's no change in the regimen during hospital stay, patient can be discharged on same. But if someone is having newly diagnosed diabetes, so required tremendous increment in doses in drugs or initiation of insulin, then the patient can be discharged on the insulin or coupled with the drugs metformin and DPP-4 inhibitors. Patient should be educated for the diet, exercise, hypoglycemia management, insulin technique if the patient is on insulin, how to maintain a log, and the sick day guidelines, and there's some education can be provided for the self-adjustment of insulin. The patient should be advised monitoring, and a follow-up plan should be arranged for that patient so that he can consult either in person or telephonically with the physician. Thank you so much for your attention.
Thank you very much, Dr. Yashdeep Gupta. We will now move on to another comorbidity, that is heart disease along with COVID-19. And we've already had one grand round which looked at heart disease, but this is focusing on heart disease as a comorbidity, which is very important because as diabetes, heart disease, hypertension, and coronary artery disease or other heart disease are also comorbidities which can lead to a poorer outcome as far as COVID-19 is concerned. So to present a case and discuss this topic, we have Dr. J. Rellan, who is a senior resident in cardiology, and I would request him now to present his case and discuss the topic.
A very good afternoon to all of you. I'll be discussing the topic COVID-19 and heart disease. So cardiovascular comorbidities are common in patients with COVID-19 infection, and there is ample data to suggest that presence of cardiovascular disease is associated with increased morbidity and mortality in patients with COVID-19 infection. Management of cardiovascular diseases in patients with COVID-19 presents several challenges, and I'll be discussing some of them in a while. I'll start with a case discussion. A 4-month-old male infant presented to us in the pediatric emergency with chief complaints of excessive sweating and fast breathing during feeding, associated with poor weight gain for 1 month, and progressively worsening breathing difficulty along with decreased water intake for 1 week. There was no history of fever, cough, cyanosis, or recurrent pneumonia. The birth history was unremarkable with a low birth weight of 1.9 kg. There was no history of congenital heart disease in the family. There was no history of recent fever or COVID-like respiratory illness in the family. On examination, the child was afebrile. There was tachycardia and tachypnea with oxygen saturation of 95% in room air. Anthropometry wise, the child has a low weight, length, and head circumference with respect to normograms for age. On systemic examination, cardiovascular system examination revealed presence of a large left to right shunt lesion with pulmonary arterial hypertension and congestive heart failure. Respiratory system examination was suggestive of presence of a localized lower respiratory tract infection. Other system examination was normal. This was the X-ray at admission, which showed presence of cardiomegaly along with increased pulmonary blood flow. There were some heterogeneous opacities seen bilaterally, with more being seen on the right side than on the left side. This was the echocardiogram of the patient, which showed presence of dilation of the left side of the heart, and there was a defect, that was a large communication present between the right and left ventricle. In addition, there was small muscular defects as seen on this parasternal short axis wave. So the child was planned for admission to our unit because of congestive heart failure as well as lower respiratory tract infection. So as part of our institutional protocol, a CBNAT for COVID virus was sent, which turned out to be positive. So the patient was transferred to the COVID facility of our center. These were the investigations on the first day. There was some anemia with HP of 9.7 gram %, and there was elevation of hepatic enzymes suggestive of congestive hepatopathy. So the full diagnosis was a large inlet ventricular septal defect with additional small apical muscular VSTs, along with severe pulmonary arterial hypertension and congestive heart failure, and now the child had presented with severe acute respiratory illness, possibly due to COVID-19. So the child was started on oxygen inhalation and IV fluids. IV antibiotics were added empirically in view of the presence of lower respiratory tract infection, and decongestants were also added because the child was in congestive heart failure. With this therapy, the child improved over the next 4 days, but after 2 days again worsened in form of decreased activity and tachypnea. The chest X-ray revealed presence of a right upper lobe collapse, and the child had to be intubated and intensive physiotherapy was started. With this, the child did improve, the lung opened up, and the child was weaned off ventilation over the next 2 days and improved over the next 1 week. On day 11, COVID testing was repeated and was found to be negative. So, the child was shifted to the cardiology ward for further management. Their child continued to be in congestive heart failure despite optimal treatment. So it was discussed with family that as the child was at high risk because of presence of COVID and a very low weight, so the surgery carried certain risk. So after consent from the patients, the child was operated on 1st September 2020, that is 3 weeks after becoming COVID negative. In the post-operative period, the child remained stable and was extubated on post-operative day 4. Unfortunately, there was again worsening in form of tachypnea, and which required significant respiratory and inotropic support. Investigations found that the child was having bacterial pneumonia and sepsis. Currently, the child is stable and improving in the ward. Coming on to impact of COVID-19 on patients with congenital heart diseases. Patients with large left to right shunts, for example, a ventricular septal defect, are at higher risk from viral infections due to increased pulmonary blood flow. There are multiple studies to support this. One such study was published in NEJM in 1982, which showed that patients who had congenital heart disease and concomitant respiratory syncytial virus infection, they had a very high morbidity as well as mortality. There is significant overlap of symptoms between patients with COVID-19 and congenital heart disease. For as in both cases, there can be respiratory difficulty, and so one may mimic the other and lead to delay in diagnosis and management of the primary pathology. Similarly, the significance of fall in oxygen saturation in patients with cyanotic congenital heart disease is difficult to ascertain because both COVID-19 as well as the cyanosis in the patients with cyanotic congenital heart disease cannot be explained by the other. So COVID-19 causes higher morbidity and mortality in patients with congenital heart disease. Thromboembolic events have been seen to be associated with COVID-19 infection, and this is of particular concern in patients who are being planned for cardiac surgery, as cardiac surgery involves use of cardiopulmonary bypass, which is in itself is a strong predictor of thromboembolic events in the post-operative period. So during this pandemic times, there has been a drop in intervention and surgeries throughout the world across all specialities. This is the data from our center in patients with congenital heart disease. So this orange bars show the interventions that were carried out in the months of April to July in the year 2019, while the blue bars show the interventions and surgery that were carried out in 2020. So the total number of interventions from April to July in 2019 were 87, and that has significantly dropped to a number of 14. Similar thing has been seen in the total number of cardiac surgeries, which have dropped from 411 in the same period in 2019 to 43 in 2020. There has been a milder reduction in case of emergency cardiac surgeries, which have dropped from 58 to 35. So, are heart disease patients more likely to catch COVID virus infection? The answer is no. But if they do get infected, then the outcomes are likely to be worse than usual. So, this is data from China, in which they saw the effect of age and comorbidities on the case fatality rate. This graph shows the effect of age on the case fatality rate. Patients who were less than 50 years old had just 1% case fatality rate in comparison to patients who were in 80s and had a high case fatality rate of 14.8%. This graph shows the effect of comorbidity on the case fatality rate. Those who did not have any comorbidity had just 1% case fatality rate, while the highest case fatality rate was present in patients who had cardiovascular disease of about 10.5%. This is a forest plot from meta-analysis which included pooled results from 25 hospital-based observational studies. It was seen that the relative risk of mortality in patients who had cardiovascular disease along with COVID-19 infection was 2.25. So, patients with cardiovascular disease are at significantly greater risk of mortality from COVID-19. Coming on to hypertension, initial reports from China were suggestive that hypertension is one of the most common comorbidities present in 20 to 30% of cases and is associated with the need for ventilatory support. However, recently other studies have suggested that when this is adjusted for other factors, hypertension per se may not be an independent risk factor for severe complications or death. Treatment of hypertension should follow the existing recommendations as for non-COVID patients in all COVID patients as well. So there have been speculations about use of ACE inhibitors and ARBs in patients who are affected by COVID-19. And this is because the COVID virus uses the same ACE2 receptor for entering the host cell. This has been refuted by two large studies which were published in May 2020 in NEJM. This is data from one of them, which showed that the severity of clinical manifestations was not very different in patients who were on ACE inhibitors or ARBs in comparison to those patients who were not on these. So the message is that the ACE inhibitors as well as angiotensin receptor blockers do not increase the chance of getting infected with COVID virus in the community, and those who are already on these drugs and they do get infected, they do not have worse outcomes. This is the statement from European Society of Cardiology, which was released on 13 March 2020, and they strongly recommended that patients and physicians should continue treatment with their usual antihypertensive therapy, and this statement has been supported by other societies as well. Coming on to ST elevation myocardial infarction. So the conventional management options for STEMI include firstly primary percutaneous coronary intervention or PCI, which is the therapy of choice if feasible within 120 minutes of door to balloon time. Second is pharmacoinvasive therapy, and this is done when the expected door to balloon time is more than 120 minutes. In this, first thrombolysis is performed, and when patient reaches the center, then PCI is performed within 2 to 24 hours of the complaint. Third option is thrombolysis, which is done in centers where PCI is not available and when thrombolysis is not contraindicated. There have been certain challenges in COVID-19 times. The primary PCI pathways may be delayed due to logistic issues such as implementation of the protective measures. Also, the personnel and equipment are limited in current times because of diversion for care of COVID-19 infection patient. Coming on to management of acute myocardial infarction. So patients who present with acute myocardial infarction should be assessed for hemodynamical stability. If they are stable, then as per institutional policy, they may undergo thrombolysis or percutaneous coronary intervention. In case thrombolysis fails, then they have to undergo a percutaneous coronary intervention. In patients who are unstable and have continuous symptoms or continue to be in hemodynamic compromise or have arrhythmias, they would also require to undergo percutaneous coronary intervention. Coming on to chronic stable angina. Continuation of medications in chronic stable angina is mandatory during this pandemic, and these patients should be followed up using telehealth. Revascularization must be postponed in patients who are at low to intermediate risk, while those who are at high risk may be considered for revascularization, and during the procedure, all the standard recommended procedures should be followed. PCI may be preferred over coronary artery bypass grafting in selected patients, as surgery has been seen to significantly increase the morbidity and mortality in these pandemic times. Invasive management in COVID positive patients should be deferred until the patient has recovered whenever possible. Heart failure. Coming on to heart failure patients may not mount a fever, and the symptoms of cough and dyspnea as because of COVID may masquerade as worsening of heart failure. So one should have a low threshold for testing in these patients. And ACE inhibitors should be continued since these drugs have shown mortality benefit for patients with ventricular dysfunction. Coming on to arrhythmias. So whenever indicated, urgent device implantation should be performed in patients with or without COVID-19 infection in this pandemic times, but the direct contact should be limited and appropriate PPE should be used. All elective catheter ablation procedures for tachyarrhythmias should be postponed, and antiarrhythmic medications may be intensified if required. In critically ill patients with COVID-19 infections and recurrent sustained ventricular tachycardia or fibrillation, amiodarone is the antiarrhythmic medication of choice, but one should be cautious about the risk of QTC prolongation, especially when used with hydroxychloroquine or azithromycin. So many cardiac patients receive anticoagulation because of presence of prosthetic heart valve or atrial fibrillation. So the anticoagulation strategy may need to be modified in patients who have a severe COVID-19 infection. Those who have a mild to moderate infection, one may continue the same treatment as before, but when there is severe COVID-19 infection, the oral anticoagulation may have to be switched to parenteral anticoagulation with low molecular weight heparin. Coming on to drug interactions between medications used for treating COVID-19 and the cardiovascular medications. So patients who are being treated with hydroxychloroquine or remdesivir, so there is a chance of prolongation of QT interval if they are also on beta blockers or other QT prolonging drugs. So one must monitor the ECG for QT interval. If methylprednisolone is being added to a patient who is already on warfarin, then INR may not be in the therapeutic range and needs to be monitored. Antiretroviral drugs have significant interactions with a lot of cardiovascular drugs such as warfarin, statins, newer oral anticoagulants, as well as antiarrhythmics. So one needs to monitor the INR and ECG for QT interval and may need to avoid drugs such as apixaban and rivaroxaban. The drugs favipiravir and tocilizumab have been safely used in patients with cardiovascular disease and no significant adverse effects have been reported. To summarize, patients with heart disease have higher morbidity and mortality due to COVID-19. In most cases of heart disease with COVID-19, management should be as for non-COVID patients. Less invasive modalities of management are preferable due to logistic issues and higher complication rate in this pandemic time. And knowledge of interaction between cardiovascular medication and COVID-19 medication is important to achieve an optimal outcome. Thank you.
Thank you very much, Dr. Jay, for presenting the case and discussing the topic. We'll go on to the final topic as far as the case presentation is concerned, and this is also something which is very important. Because of the pandemic and the associated effects that it has had in terms of the lockdown, in terms of physical distancing, there have been a lot of mental health issues that have happened. But this grand round is going to discuss mental health as a comorbidity. So we will be discussing mental illness as a comorbidity with COVID-19. And for that, we have Dr. Kaushik Sinha Deb, from Associate Professor from the Department of Psychiatry, and I'll hand it over to him. Hand it over to you, Dr. Kaushik.
Thank you, sir. And thank you, the respected my teachers on the dais. And a very warm welcome to all my colleagues across the country. As our life becomes more and more dominated by our cognitive and mental work, our mental health cannot be neglected anymore. But the interaction between COVID and mental health is so multidimensional that it's difficult to cover. The population that can be affected by COVID includes the general population to some extent. Of them, slightly more affected would be persons in isolation, then family members of patients because their level of stress and stresses increase, and finally COVID-19 patient. And cross-cutting across all these various stress zones would be special populations like healthcare workers, other frontline workers, and vulnerable populations. For example, people with pre-existing mental disorder, people having the elderly, the frail, with other comorbidity, both psychiatric and medical comorbidity. They form a definite special population who get affected more by the mental health issues. But then when you look at the various mental health issues, what we see is that there are two groups. A broader group of person gets affected by mental health symptoms, which include anxiety, fear, low mood, sleep, appetite, headache, or other somatic symptoms not amounting to psychiatric disorders. So a subsection of them will be suffering from depressive disorder, anxiety disorder, PTSD, delirium, and psychosis. But for today's, and of those subsection who have got a psychiatric disorders, a certain fraction would be having pre-existing disorders, which would be presenting more frequently to the emergency because of lack of routine services, or they will be presenting to the emergency with psychiatric emergencies themselves, which can happen because of substance withdrawal or substance overdose. For example, alcohol withdrawal and overdose, and suicide or self-harm attempts. But for today's case presentation, we'll be focusing mostly on the central part of patients of COVID-19 with psychiatric disorders, how to manage them. The rest maybe can be taken up later. So for the case, we'll be presenting a case, a 24-year-old unmarried male who is currently residing alone in Delhi for the last 5 years for studies. And he presented to our emergency with an attempt of self-harm and with depressive symptoms. The person was diagnosed previously in 2017 as obsessive compulsive disorder, and he has been managed regularly at our AIIMS OPD, and he required admission in 2019. But since 2019, he was maintaining all right. In March, when the lockdown started and the college stopped, the patient started worrying about the future, which resulted in some physical symptoms, including sleep decrease. The patient also stopped going out, and therefore he stopped cooking because he was not buying vegetables and would subsist mostly on packaged food. He complains that he was feeling lethargic. He stopped watching the TV because of anxiety about his career and no good news was coming. And subsequently, he had decreased sleep, reduced appetite. His self-care gradually got down because because he is not going out, he would not take proper care or take a bath on a daily basis. In April, with the increasing of the fear regarding COVID, his hand washing, which is a part of his obsessive compulsive disorder, which primarily include ideas of contamination, that things are dirty, and the compulsion being he has to wash his hand repeated times, he started washing hands and justified it to himself by saying that everybody is doing it, even the government is saying it. He also started rechecking all foods and vegetables, thinking that they might not be properly sanitized, their expiry date must have passed, so on and so forth. In May, ultimately, the patient decided to stop all medication because one was to go out and purchase the medicine was difficult and he could not come and get his free monthly supply from AIIMS. And also he had the idea that medicines cannot solve this problem or his career issues. Ultimately, after about 4 to 6 weeks after stopping medication in late June, his symptoms exacerbated significantly, late June and early July. There was significant dysfunction in routine sleep, appetite, self-care. The patient started having ideas of hopelessness, helplessness, worthlessness about self. And then he started to feel his life is not worth living. He felt it would be okay if he passed away. Initially, there were indefinite plans, but often the person in bouts of anxiety and when he was unable to control his hand washing would have definite active suicidal planning. So finally, in August 2020, he consumed 2 to 3 assorted tablets of clonazepam fluoxetine. Luckily, he felt worried and afraid and anxious, so he immediately contacted his neighbor to accompany him to the AIIMS emergency. And a mental status examination revealed severe depressive episode with high risk of suicidality and comorbidity of OCD. So this case, the history kind of highlights how the whole pandemic plays out along with other mental disorders. However, after the initial assessment, a plan was made to admit the patient to psychiatry ward, but the screening test for COVID-19 came out to be positive, and therefore the patient was finally shifted to our COVID center in the trauma center. Now, from a pure psychiatric management perspective, the management of this case otherwise would have been easy in a sense that reinstitution of medication should be done. For anxiety, temporary management can be done with benzodiazepines and other anti-anxiety drugs, and agitation, which was initially there, particularly with the added fear of how the person is going to adjust to a ward with other COVID patient and where he is going to wash his hands and what would happen to his obsessions, were initially required a little bit of olanzapine and antipsychotic to manage the agitation. And other things that are generally required in such cases are 24-hour supervision, regular counseling, but more importantly is the long-term follow-up. The medical management was mostly supportive along with monitoring. But the issues that we faced in this case were primarily the difficulty in admitting a suicidal patient in open ward. So in most cases, an additional staff is provided by the hospital or the family members stay. But in COVID ward, none of them are possible. And then there is that ethical question of whether you can have a 24/7 attendant while knowing that exposure to COVID in the COVID ward might actually make him more vulnerable to the infection. So all nursing officers, security officers, guards, residents were informed, and we had a small impromptu training about how to do a proper handoff or handover, in which one person before leaving the duty has to tell the next person coming in directly about the specific issues with this case. And a WhatsApp group was created because most of the residents would be inside PPE, and that WhatsApp group was a central repository where all the decisions were communicated with one another. The same thing for maintaining the continuity of care between the rapidly changing medical and psychiatric teams, which were about 8 hours each. So a combined round and telephonic briefing to the outgoing resident and the incoming resident would be done. And we saw that having the primary responsibility assigned to one resident, irrespective of his duty hour, where he is communicating with the on-duty resident through telephone, might actually help in better management of the case. And finally, communication and supervision by the team, which was seen before, helps in such cases. Communication with the family members was an issue, but we are lucky that the trauma center, the COVID center, had formed a dedicated communications team, which helped us a lot in communicating with the family members. The final hurdle was in managing discharge, when to discharge, to be discharged early or late, to follow a guideline of 10 days. Is he actually negative, or should the patient be transferred to psychiatry ward? And if he is transferred home, how do we send the patient home? How to ensure 24/7 supervision? So we had to take help of social service. We had to plan somehow to get his family members there, and so on and so forth. Final point was to ensure medication compliance, in sense that it's difficult to procure medication in times of lockdown, and people who are dependent upon the free government service, they feel they are particularly vulnerable, and therefore we had to devise a way for the patient to come here and get his medicines. The primary learning that we had from this case is team building, and more importantly, role and responsibility sharing. A psychiatry resident, while in the COVID ward, would have to do responsibilities which a normal psychiatry resident would not do. But I'm happy to share that many of the medicine residents and the anesthesia resident, they would spend 1 minute, 2 minutes with the patient, just assuring him. And sometimes even that is enough to support or to ground a suicidal patient, so that his anxiety and distress decreases. So a very brief review of literature. There are a lot of meta-analyses which have also come out, but this one particular from last month's Lancet stands out in a sense. It compares the prevalence of various COVID-related mental disorders along with the other, compared to the other previous MERS and SARS infection. The nutshell of that, the summary of that is the levels of the psychiatric morbidity that we are seeing in COVID is very similar to that we have seen in MERS and SARS previously, which essentially means that the COVID virus does not cause something like an autoimmune encephalitis or autoimmune psychosis. What we are definitely seeing is that there is increase in delirium in a significant proportion of patients in the acute stage compared to the previous infection. So that should be taken care of and remembered by the critical care team. So the good thing is that the possibility of most patients should recover without experiencing mental illnesses. But the possibility of depression, anxiety, fatigue and PTSD, it should be checked in long term, for which currently data is not available. So the summary of the global data from the various other meta-analysis review and narrative reviews which has come out show that around 40% of the psychiatric patient who are admitted to the COVID ward would have, 40% of the patients admitted to COVID ward would have psychiatric symptoms. And this value is considered underreported because generally in critical care scenario, only those patients with more severe symptoms gets picked up because there are other pressing priorities which are competing. Of them, a large fraction is delirium, but anxiety disorders, depressive disorders are there. PTSD, like I said, psychosis is found in less than 1%, and there has been a national UK data of all the COVID patients. The psychosis levels are pretty less. Substance use disorders, which has a lot of country variance, is also coming up in these studies in a sense, either because unavailability of substances, replacement of one substance by another, and so on. We have been doing a small study under Dr. Satpathy and Professor Chadha and other faculty members. So this is a data from our own Jhajjar, in which 461 patients were seen, and admitted COVID positive patients were evaluated with HADS, which is a hospital anxiety and depression scale. And we found that our data is relatively matching with that of the global data, in that around 20% had a significant score in HADS, the depression part, and 22% had an anxiety part. What was shown there is, apart from all the other factors like the Lancet study showed that female gender is a factor, socioeconomic state is a factor. Lockdown was also a significant stressor. So there has been a decrease in anxiety, depression post during the unlock period. Some studies specifically focusing on healthcare workers say that although they might not be having psychiatric disorders, headache, sleep disturbance and low-grade anxiety symptoms are very common in them. So finally, if you have to assess, we have to understand that any person who is complaining of some psychiatric symptom does not have a psychiatric disorder, because the diagnosis is not only based on symptoms, but also a certain duration, a distress and a dysfunction which can be established to call a diagnosis. So if there are a large number of patients and maybe the clinical resources are not available, even nursing staff and other healthcare person can use certain screening instrument. The commonest would be patient health questionnaire or GAD-7. Which can help in picking up certain patients admitted with COVID if they request specific attention from the clinical staff or from a specific psychiatry or a mental health professional. Another question or area which needs to be seen is the suicide risk of patients who are admitted with COVID. And like the rule of the thumb, the past history of suicide is a very important risk factors, but one has to see other things, including comorbidity, both psychiatric and medical. And one has to see if the ideas are passive, diffuse, or there are active, definite ideas. Then one needs to look into the frequency and intrusivity. If there is one scale that the WHO also preferred, it's the Columbia Suicide Severity Rating Scale. One should go through that because it has a very nice step-by-step approach about how frequently the thoughts are, how serious the thoughts are, what have been communicated, what acts has been done previously, what preparations has been taken, so on and so forth. So that gives any clinician some idea about how to assess the risk of suicide. Pharmacological and non-pharmacological, since most of the patients have psychiatric symptoms or mental health symptoms not amounting to disorders, the primary thing should be common sense psychology, which include behavioral alteration, including sleep, routine, exercise, diet, and some form of coping. It can be spiritual coping, it can be active coping, like communicating with others, discussing their problems. And in cases where help is required, the professional help should be sought. The Indian government has come out with a telemedicine guideline, of which NIMHANS, along with the IPS, Indian Psychiatric Society, they have finalized the telepsychiatry guidelines, which says that these drugs are relatively preferred for sleep, clonazepam, for as a SSRI, for anti-anxiety antidepressant escitalopram, because it has the least interaction with other drugs, of the antipsychotics olanzapine, and of the mood stabilizers valproate. But for admitted patient where there is a need, lorazepam might also be preferred because of its safety in liver profile, and many liver disease patients are also admitted. SSRIs, escitalopram is again preferred because of least interaction of the antipsychotics olanzapine, risperidone, which have a shorter onset of action, and for injectable haloperidol because it's available in various doses. Delirium also requires haloperidol because benzodiazepine should be avoided, or any other anticholinergic should be avoided, but delirium haloperidol at a very low dose has the highest evidence because it's there for the longest time and we regularly use it. So the summary of that, mental health problems have been called kind of a pandemic within a pandemic, and it's the stigma of mental disorders that gets redoubled by the stigma of COVID, which prevents people to communicate about their mental problems. And therefore, if awareness, early detection, and proper management with minimal medication are necessary, and the only way to go forward that we have seen during this time is a combined care with medicine and critical care teams. So a team-based approach is the way to do. But the thing that is also to be remembered, that once a patient is discharged from the COVID hospital, a follow-up and continuity of care either through telemedicine or through OPD follow-up is required. I think that would help of all of us in understanding and managing psychiatric problems in COVID patients. Thank you.
Thank you very much, Dr. Debs. Before we go on, I would just like to introduce the panel that we have today. On my right is Dr. Nita Saxena. She is the Dean Academics and Professor and Head Department of Cardiology at the All India Institute of Medical Sciences. On my left is Dr. Nikhil Tandon, Professor and Head of Endocrinology at the All India Institute of Medical Sciences. And next to him is Dr. Rakesh Chadda, who is Professor and Head Department of Psychiatry and Chief of the NDDTC of the All India Institute of Medical Sciences. We'll also have Dr. Animesh Ray after his presentation, who is Associate Professor in the Department of Medicine. Before I go on to the case discussion, just one or two quick questions to all of the panelists. One is, because we had the first case of diabetes, to Professor Nikhil Tandon. How common is it that the patient may present who has diabetes with COVID-19 as diabetic ketoacidosis? Do you think we should keep that in mind in any patient now who's presenting with DKA?
So anybody who's coming into an emergency situation will, I think, necessarily should have an evaluation for a coexistent COVID disease. The issue is that there may be certain features in that patient when they arrive at emergency, because you can get fever, you can get leukocytosis, and you can get a range of other biochemical abnormalities. With the fever, these abnormalities may flag this particular individual as a possible COVID candidate, and while he or she is being stabilized in the emergency setting, I think it's always advisable to go ahead and perform a COVID test. The second thing also is that in a person who has known type 1 diabetes, we know that infections can precipitate diabetic ketoacidosis. So somebody who's otherwise well, who said that they've been taking their diet regularly, they've been taking their insulin properly, but they still get into an episode of diabetic ketoacidosis. In any case, we need to look for infections, and in the current scenario, we therefore necessarily also have to look for a concurrent COVID disease.
Thank you. I think that's important. One question to Professor Anita Saxena. An excellent case, a young child who had presented with a number of problems, and the fact that this child underwent surgery during the time of COVID. The question that I have is that, as was mentioned in the case, thromboembolic events tend to be more common in such children. So in such a case, should there be early institution of anticoagulants in a person who is COVID-19 positive?
Yeah, I think overall children beyond 1 or 2 months of age do not usually develop thrombosis. So generally they are much better off, and our use of anticoagulation is much less in children as compared to adults. So yes, that's not true for very small infants like under 1 month. But between 1 month, from 1 month onwards, our requirements are usually not so high, and we don't often use. But I think in cases of COVID, where we know that thrombosis is an issue, anticoagulation could have been used. In this particular patient, we did not use any anticoagulation because I think as a protocol, we have not been using anticoagulation in children under 1 year of age.
Okay, thank you. And then a final question to Dr. Chadda regarding, we had this case who had come and was admitted, but what about the challenges that you would face in patients who have mental health issues, are COVID-19 and are in home isolation? How would you manage that?
Yes, patients with COVID and mental health problems who are at home is a big challenge because as such, COVID has added to the mental health issues, the stress of COVID, and uncertainty of improvement, anxiety, and the person is can be counseled or can be contacted only on, say, if he or she is able to access the mental health services with a psychiatrist. A general suggestion would be, in case of milder symptoms, generally for mental health problems, medications are not required. Simple anxiety management techniques like deep breathing exercises, abdominal breathing, yoga, maintaining a regular routine, not going for too much of information on the social media, and talking to the family members, keeping a social contact. All these are generally helpful, and keeping a regular routine, adequate sleep hours, plenty of fluids, and staying away from drug and alcohol, because drug and alcohol would lead to addition of more worsening of problem rather than providing any kind of relief.
Thank you very much. We will have a detailed discussion and answering your questions after the presentation. I would really request you that if you have any questions, please send them through WhatsApp at our number, which is there at the bottom, but I'll repeat it also. It's 9999692364. That is 9999692364. So please send your questions or queries that you have through using WhatsApp on this number. Now we go on to the topic discussion, which is challenges of managing comorbidities with COVID-19. And I would request Dr. Animesh Ray to take us through this topic. Dr. Ray.
Thank you, sir. Good afternoon, everybody. So the next 15 minutes, I would be dwelling on the challenges of managing comorbidities with COVID-19. Now, 9 months into the pandemic, and after clocking more than 28 million cases and close to 1 million deaths, there are several aspects of this enigmatic disease which is becoming prominent, and one such is its association with comorbidities. If we look at the initial case series from Wuhan, from where it all started, the relationship of COVID-19 with the different comorbidities was apparent right from the beginning. So if you look at this table, all those patients who were having hypertension, diabetes, coronary artery disease, and other comorbidities, they had higher chance of dying. So they had higher chance of not surviving COVID-19. So is this association between comorbidities and a critical illness a newfangled idea? It is not. We know that there are several prediction scores like the Apache 2, which takes into account these comorbidities. So if the patient has these comorbidities like heart failure, cirrhosis, lung disease, and so on, so their chance of faring poorly as far as outcome is concerned increases. There are several studies, one such is from a recent article in Lancet, which talks about the importance of comorbidities. So if you look at this, so the deterioration of the acute physiology score, so like hypertension, respiratory failure, presence of these deterioration, they are as bad as presence of different comorbidities. So the history at admission of different comorbidities, they actually portend a worse outcome in all patients of critical illnesses. So if we look briefly at our experience, over the last 15 days from a ward and trauma center who had their outcome defined. So we had a total of 137 patients, out of which the majority belonged to the mild COVID and the asymptomatic group. So almost that was around 83%, while a minority around 17% belonged to the moderate and the severe COVID-19 bracket. The average length of hospital stay over the whole cohort was around 10.3 days, while the average length of hospital stay for the asymptomatic or the mild COVID-19 disease was a little less, 9.5 days, but it's almost there, near the average. The reason for this, out of other reasons, was the presence of comorbidity, which was almost present in almost all the people except barring 2 individuals. So if you look at the distribution of comorbidities, as is expected, hypertension was the most common, followed by diabetes as well as malignancy, and 1 out of 4 patients, they had multiple comorbidities. Talking about the outcome, out of 137, 128 were discharged, and 9 patients succumbed, out of which 6 patients, they belonged to the asymptomatic mild COVID-19 disease, while 3 were severe or critically ill. So talking about COVID-19 and comorbidities, the list is actually endless. So a number of comorbidities might have a telling effect on the course of COVID-19, and some of my previous speakers, they have already dwelt on that. So I'll be talking about a select few. If you take into consideration any comorbidities and its relationship with COVID-19, well, the relationship can be conceptualized according to one of the 4 points, that is the effects of comorbidity on critical illness and mortality, effect of comorbidity on management of COVID-19, effect of COVID-19 on management of primary comorbidity, this is the reverse of the second point, and finally asymptomatic COVID-19 and how it pans out in cases of COVID-19 disease. So briefly about critical illness and mortality, I had already alluded to it from the initial case series. So patients of COVID-19, if they have comorbidities like heart failure, diabetes, or increasing age, they have higher risk of having critical illness. So this was from a study done in New York, more than 5,000 patients, and they surmised this. In this study, they talked about the chance of being discharged, staying alive at the end of the hospital course, or dying. So if you look at this graph, so this violet line talks about probability of getting discharged or being alive, while the yellow broken line, it talks about dying. So if you would see that in the presence of different comorbidities, heart failure, cancer, diabetes, these lines, they converge. So indicating that in presence of these comorbidities, there was a higher chance of dying as far as association with COVID-19 was concerned. The same held true for increasing age more than 65 years, as well as age more than 75 years. This particular point was more prominent. Talking about hazard ratios, this was again a study from UK. It was a very large cohort. It talked about the hazard ratio for deaths in COVID-19, and they enumerated a number of comorbid conditions: diabetes, cancer, hematological malignancy, reduced kidney function, chronic respiratory disease, chronic cardiac disease, as well as chronic liver disease and other comorbidities. And they showed that association of COVID-19 with these comorbidities led to increased death in these patients. Ditto for obesity. It was seen that patients who had BMI more than 40 or more than 45 and who were especially young, less than equal to 60 years, or who were of the male gender, they had higher chance of dying due to COVID-19. Coming to the second point, that is the effect of comorbidity on management of COVID-19. So this is very important for all those personnels who are working in the COVID-19 ward and managing patients. So there are certain antivirals, they cannot be used in the presence of certain comorbidities. The most important example being remdesivir, which contains cyclodextrin, which accumulates in kidney disease patients. So anybody having a GFR less than 30 ml per minute cannot be prescribed remdesivir. Similarly, those who have ALT more than 5 times the normal limit, they can also not be given remdesivir. HCQ has got significant drug-to-drug interactions with remdesivir. So autoimmune disease patients on hydroxychloroquine cannot use remdesivir. We know that HCQs also, they have a very long T-half. So any patients on hydroxychloroquine, remdesivir cannot be used. The same holds true for favipiravir, which is an antiviral, though less commonly used. Even tocilizumab, which is an IL-6 inhibitor, it cannot also be used with ALT more than 3 to 5 times the normal limit. talking about steroids and adverse effects, one of the previous speaker had already talked about one of the adverse effects of steroids, that is hyperglycemia. Now, secondary infection is another prominent adverse effect, but the caveat is that we know that steroid is one of the agents which in moderate and severe COVID-19 patients actually gives mortality benefit. So this was the data from the recovery trial which showed that even in the presence of hyperglycemia, steroids have to be given, although with proper management of hyperglycemia. So what happens when one pandemic interfaces with another pandemic? So HIV, COVID-19 is thought to have a significant impact on people having HIV. It is thought that severe COVID-19 and mortality may be higher in this population, partly because a lot of HIV people living with HIV, they have comorbid conditions, including heart diseases. So since these people have comorbid conditions, their chance of faring poorly increases in presence of COVID-19. There was the initial enthusiasm about using lopinavir-ritonavir so that this agent can target both HIV virus and COVID-19, but now it has been shown that this has not got much use in COVID-19. So the use of lopinavir-ritonavir is actually not recommended in presence of COVID-19. How does COVID-19 impact on the management of the primary comorbidity? So one such example which has been discussed, but I would just like to emphasize that the ACE inhibitor and the ARBs, they should be continued. And we have also referred to the study which showed that. So ACE inhibitors and ARBs, if they are used, they do not lead to increased chance of either COVID-19 disease or increased chance of having severe COVID-19 disease. So use of these are absolutely recommended. Statins have to be continued. So all those patients having chronic obstructive airway disease, COPD, asthma, they should continue to use the inhaled medications, especially those people who are in the ward. Attempt should be made to use MDIs rather than nebulizers because of the chance of aerosolization with nebulizers. What about CKD and COVID-19? So here patients with patients having chronic organ involvement like CKD and CLD, it is usually recommended that they stay at home. So all those CKD patients who avail home dialysis, they should be encouraged to follow up by telemedicine. However, when dialysis access placements or other procedures are indicated, then they should not be deferred. Some dialysis centers stress on COVID-19 negative reports. So a lot of COVID-19 patients having CKD who are admitted, they end up staying in the hospital for a long time, awaiting the result of a negative COVID-19 report. What about liver disease and COVID-19? So liver disease, we know that COVID-19 can give rise to increased transaminases. Also in patients with CLD, this effect is seen. Some of the larger cohorts, some of the larger registry are actually shown increased risk of mortality in patients having CLD. So all those CLD patients with COVID-19, early admission is preferred. And besides the common antivirals, the other management strategies include infection control, mitigation, risk stratification, and supportive management. There are a number of studies which stresses on the different basic principles of managing CLD. So ASLD, ASL, they talk about that. So the basic tenets are, again, you stay at home, you stay calm, and you seek medical help when there's an emergency. Otherwise, you avail telemedicine and keep in contact with your doctor. What about solid organ transplant? So a lot of kidney transplant patients, they get admitted to our trauma center, to our COVID hospital. So in these patients, there's a theoretical risk of transmitting disease to a recipient from a donor, that is before the surgery. So all transplant donors, they should undergo RT-PCR before the transplant surgery. Now, post-transplant also there's an increased risk of contracting COVID-19 because of a number of reasons. One is they are on chronic immunosuppressants. Second is there is an increased healthcare, there's increased contact with healthcare services. And some of the manifestations may also be dissimilar in these patients having solid organ transplant. Most commonly, they have less chance of fever because again, they are on immunosuppressants. And these patients might also have more severe illness than the other population. Another common thing which is faced in the ward is the drug-to-drug interactions between the calcineurin inhibitors, tacrolimus, and cyclosporin, and some antivirals used like HCQ and azithromycin. So, dose adjustment have to be done, and HCQs, azithromycin, typically in this scenario they are stopped. Some adjustment of the other immunosuppressants, they are also done. Typically, the anti-metabolites like mycophenolate is stopped, CNI is continued, and the need for steroids are typically individualized. Finally, a little bit about asymptomatic COVID-19. Now, initially, when the COVID-19 pandemic started, it was thought that the COVID-19 patients belong to one of the following brackets, that is mild to moderate, which was the most common, followed by severe critical, which was a minority. But now, with passing time, it is being realized that a significant proportion of COVID-19 patients are asymptomatic. So the estimate has consistently increased over time. So initially from the Diamond Cruise, it was 19%. To this study, it was 31%. And the recent seroprevalence studies, they actually show that more than 97% patients may be actually asymptomatic. So the problem with asymptomatic COVID-19 is that the viral shedding may continue for months without much risk for transmitting the infection. So if you would look at the graph here, so even up till week 5 and some say up till week 12, there might be RT-PCR positivity, even though the patient may not be infectious. And these asymptomatic patients, due to their underlying comorbidities, they might actually present to the hospital with some unrelated symptoms and with RT-PCR positivity, and they would be labeled as COVID-19 and shifted to a COVID facility. So just two short examples. A 45-year-old female, ongoing treatment for pulmonary tuberculosis for 2 months, had on and off hemoptysis, not responding to conservative treatment. However, she had no COVID symptoms, referred for bronchial arterial embolization in view of the hemoptysis. Her RT-PCR at the emergency was positive. Now she had a bout of severe hemoptysis in the ward, had to be intubated and mechanically ventilated for 4 days before being shifted to the ICU. However, she had a favorable outcome, she was weaned off the ventilator and discharged. Another patient, a 25-year-old female patient who had road traffic accident and resultant paraparesis and grade 4 bed sore, was planned for elective surgery, referred to a center with RT-PCR positivity, but mind you, she was asymptomatic from the COVID-19 point of view. Now, after 10 days and negative RT-PCR, she was referred back to the hospital. Now, her pre-op RT-PCR before debridement was positive, and she was again referred back to the COVID hospital. So there is considerable uncertainty over a positive RT-PCR in this asymptomatic population, and in many of these cases, COVID-19 may actually be an innocent bystander. We do not know when these patients, asymptomatic patients, contracted the infection, and is the patient still infectious? So there is a number of evidences which have come up, and the CDC guidelines, they reflect the evidence. So persons with mild to moderate infection do not remain infectious beyond the 10 days of symptom onset. So this is the reason why before discharge, no longer RT-PCR is recommended. For severe infection immunocompromised, the corresponding limit is 20 days. Is more. For asymptomatic, the logical deduction is 10 days from the first test. But again, this 10 days may be excessive for some patients who are presenting with unrelated symptoms. And there is no benefit of retesting within 3 months of test positivity, except for specific groups like immunocompromised. So this is my penultimate slide. So I would summarize by saying that some of the comorbidities, they lead to increased chance of critical illness and mortality in COVID-19. And in presence of comorbidities, certain alterations may be warranted in the management of COVID-19. And the opposite is also true, that COVID-19 disease may lead to modification in management of certain diseases. And finally, asymptomatic COVID-19 patients with comorbidities, they present with unique challenges which have to be appropriately addressed. I would like to end with that. Thank you.
Thank you very much, Dr. Ray. And we have a lot of questions, so we'll try and answer as many as possible. And I'll start with Dr. Nikhil Tandon, and I'll ask him the question that had come in the beginning: which insulin, fast-acting or long-acting, is best for patients with COVID-19 who are on IV steroids, and how do you calculate the dose? This was covered to some extent in the talk itself, but maybe you can just reiterate that.
So really, by the time somebody is on steroids and requires insulin, they will virtually inevitably require both a basal insulin as well as bolus insulin. So really what you need to do is, so they really serve two different purposes. Let's look at a person who doesn't have diabetes. The body produces enough insulin all the time to give a certain amount of background control, and then pushes out more insulin with every meal. So the basal insulin really is replacing that continuous low dose release from the pancreas, and the bolus takes care of the meal related spikes. And it's quite likely that a person who's on IV insulin is ill enough, and that's why they require IV insulin. And then, of course, they need to have, then the steroids themselves will result in a further heightened sugars. So you will need a basal insulin to take care of the continuous requirement, and then a regular acting or a short acting analog to be given along with each meal to take care of the full control of such a patient.
Thank you. Question to Dr. Neeta Saxena. There are actually two questions. One is, this is a patient who's had mitral valve repair and has still some degree of mitral regurgitation. Is there an increased risk, and should the patient do anything to prevent himself from getting COVID-19? And the second question is, do calcium channel blockers have any role in the protection from COVID-19?
Okay, so the first question about the mitral valve repair, if the patient is more than 6 or 8 weeks away from surgery, that means he's operated more than about 2 or 2.5 months ago, then I think his risk is not very high as long as mitral regurgitation is not significant. So in all probability, since he has undergone a mitral valve repair, mitral regurgitation severity is going to be mild or at best moderate, and the ventricular function is likely to be normal. And in such cases, there is really not more risk. But having said that, I think all these patients need to avoid any activity that can make them prone for COVID infection, because once they develop COVID infection, then we don't know in what way are they going to behave, whether their left ventricle is going to be affected in terms of myocarditis or something, which is rare otherwise, but I think they need to be protected like anybody else. Regarding calcium channel blockers, I think we have no data to say that calcium channel blockers are protective towards COVID infection, nor do we have data to say that they are not to be used. So I think if somebody is on calcium channel blockers, the recommendation will be to continue it.
It doesn't really have any protective role. There's a question also now to Dr. Chadda, which is regarding COVID delirium. How common is it, and does melatonin have any role as far as treating that is concerned?
COVID delirium is very common. Exact prevalence would be difficult to say, but 20-25% or even more patients may be having delirium, because many times it lasts for a short time and it may not be recognized. And it has to be treated with specific drugs like haloperidol. Melatonin as such does not have any role. Generally, a correction of electrolyte imbalance or any other metabolic disturbance that would resolve the delirium. Haloperidol is a symptomatic treatment.
Thank you very much. Two questions for Dr. Ray. One is there any specific treatment for a patient who is COVID positive and has tubercular meningitis? You showed a case also. And secondly, do we look at the D-dimer value in our patients before deciding to start low molecular heparin in moderate to severe COVID infection?
Right. So regarding management of tubercular meningitis in the presence of COVID-19, now these two diseases, they have to be managed by their own merit. So COVID-19, depending on which classification the patient is in, mild, moderate, severe, that should be managed along that line. And the TB meningitis, the usual management of tuberculosis, that should be continued along with dexamethasone. Regarding the second question, so anticoagulants, typically they are being used in our hospital for all those patients who are either moderate COVID or severe COVID. Now, it is not based on an increased value of D-dimers. So D-dimers, what we are seeing, they are raised in a vast majority. Even some patients of mild COVID who do not have oxygen requirement, they end up having raised D-dimers. So our decision about choosing to start anticoagulants, they are not based solely on the lab report of raised D-dimer.
I think it's important to remember that D-dimer has a negative predictive value. It can be elevated in a number of conditions, and therefore you cannot only go by a high D-dimer to decide on anticoagulants. If you have a person who has moderate COVID infection and has hypoxemia, has inflammatory markers going up, enough evidence to suggest that we should give low molecular heparin or anticoagulants. You could start in a prophylactic dose to begin with, and if the patient has more severe illness, you could even go on to a therapeutic dose. One question now for Dr. Nikhil Tandon. This is regarding a doctor who said that he's noticed that many of his diabetic patients have become hypoglycemic when they have COVID-19, and what could be the cause of that? And are we seeing more new diagnoses of diabetes within this era of COVID-19?
Well, thank you. That's an interesting observation. Clearly, what has been demonstrated in most instances is the other way around, because there seems to be an element of significant insulin resistance which comes up with a lot of these patients. And in fact, people are known to have worsening glucose control. But there is a potential mechanism by which they can have hypoglycemia. One, of course, is that they continue with their regular medication and they're so unwell that they've just stopped eating, and therefore the nutritional intake is poor, which can therefore very easily be explained on that. The second, and I think you mentioned in your opening remarks that too aggressive a regimen of anti-hyperglycemic agents may also contribute to that. So the latter, of course, will require suitable monitoring. The problem is that monitoring itself becomes sometimes difficult in a person who's COVID positive, because repeated pricks, repeated access to the patient may be difficult. Also, the predictability of appetite and the predictability of food intake may again become difficult. So those could be potential scenarios in which hypoglycemia can occur, but they're all easily manageable based on monitoring and then decision making based on that. The second question is, so there is actually a registry which has been now established for looking at newly diagnosed diabetes. It's a worldwide registry where people are expected to contribute. But I think in addition to the esoteric reasons, it's very important to understand, and I think Dr. Yashdeep in his talk gave, in a country like India specifically, and that's the relevant piece for us, the rule of halves is applicable. So about 50% of most people with chronic disease are really unaware that they have, let's say, diabetes or hypertension, and then opportunistic testing under such circumstances can unmask an existing disease, but one which is not tested. That's point number one. Point number two, which is perhaps actually quite sinister, is a stress hyperglycemia, which is referred to. It possibly reflects the severity of the underlying COVID disease, and therefore the implications for management and the implications for adverse outcomes are there. There is, of course, there have been case reports of people saying pancreatitis. There's known presence of the ACE2 inhibitor, ACE2 receptor on the pancreatic cell surface. So those could also be contributing to that. If I have your permission, I realize I didn't actually completely answer the very first question you'd asked me, and this was about dose calculation. I won't go into too much by way of detail, except that to say for basal insulin, the pre-meal sugars are really a very good marker of the total dose that's required. So if your fasting glucose is generally all right, you would tend to believe that your basal dose is all right. There are some other calculations which are provided by us in both the article referred to and in the guidelines. For the prandial insulin, that is the regular insulin given around the meal, perhaps the best assessment is looking at the delta between a pre-meal and a post-meal value. So we want the post-meal to be within 30 or 40 of what the pre-meal value was. And if you're getting that with the pre-meal shot, you're possibly in the right sort of range. So again, monitoring is critical with these broad guidance for that. Thank you.
Thank you very much. I now ask Dr. Neeta Saxena two questions. One is, is there a higher mortality of STEMI in patients with COVID-19? And is there a role of ecosprin and statins? And should it be given to all patients who are positive for COVID-19?
Thank you. Coming to the second question first, the role of ecosprin and statin. I think ecosprin, generally we believe that if if I think there was some initial report saying that EcoSprint could be protective, but I think now there is not enough data to say that one should start EcoSprint for treatment of COVID infection. Yes, many of our patients are actually on EcoSprint already, and we would continue with that. However, keeping in mind that if you are using low molecular weight heparin because of the severity of the disease, then it can actually increase bleeding risk. So one has to be careful about that. Statin, very, very interesting. In fact, a couple of days ago, or maybe a week ago, a report has come where they have hypothesized that statin may actually be given for the treatment of COVID. Again, the authors have been very, very careful, and they've said that probably more data is needed to prescribe statin primarily for COVID. Again, a lot of our patients will be on statins because of their pre-existing cardiovascular disease, and therefore, again, we would like to continue with statin in those cases. But to start statin in a person who's not on, perhaps we don't have enough data. The mortality of STEMI, I think the very fact that many centers have gone on to do thrombolysis instead of primary PCI, which is what ideally one would like to do. And there are many reasons for that besides the logistics and the delay. It is likely that the mortality may be higher. Again, I don't have data to support that, but it is possible that not just mortality, perhaps morbidity and residual ventricular dysfunction may be higher with the approach that many of the centers are following in the current pandemic, because primary PCI is supposed to be superior in terms of preservation of the myocardium. Thank you.
Thank you very much. I think very important points, and there has been a lot of speculation about whether statins can be protective. And this has been there for many other illnesses in the past. Even during past pandemics, there was the issue that if people were on statins, it could prevent them from getting a more serious illness. I don't think we have enough prospective data really to say that's so useful. A lot of this is based on retrospective analysis, which may not be that strong. One question that I have is for Dr. Dev, and that is basically the psychiatric manifestation of long COVID. That is, once you recovered from COVID and you continue to have chronic fatigue syndrome and other such manifestations, how would you approach such patients?
Yes, sir. In a sense that any chronic illness or any life-threatening situation or any stress can sometimes leave on lingering symptoms, which include a variety of non-specific symptoms, including physical symptoms. So that include fatigue, headache, appetite loss, disturbed sleep. So like Professor Chadha was saying, for majority of the things which does not meet the threshold of being a disorder, in a sense that it's not too severe that it is causing significant disturbance or distress, the management is primarily non-pharmacological, where the simple things like doing a respiratory exercise or maybe doing physical exercise, doing breathing exercise, doing yoga, those things help. However, few studies have come out which are showing that many of the patients who do not initially have any symptoms of psychiatric disorders, including anxiety disorder and depressive disorder and post-traumatic stress disorder, in which the person keeps on reliving the days in the ICU, those diagnoses or those frequency of disorders are also increasing. Therefore, if a person particularly is at any doubt, assessment by a clinician, even a medicine person and a mental health professional might be just a way to go, just to have a cutoff. And what it does, it also decreases the anxiety once a clinician has evaluated the patient and said that things are all right.
Thank you very much. I have two questions for Dr. Chadha. One is by a physician who said, I'm a treating physician in a government hospital, tested positive for COVID on 10th July. And he has diabetes, hypertension, ischemic heart disease, and now he's having increased anxiety and suffering from insomnia. He's basically now recovered from COVID because he had this in July. He's also written, should I join COVID duties? I think he's otherwise should have enough antibodies to be able to protect himself as far as joining duties is concerned. But he's having increased insomnia and a lot of anxiety. So maybe you can answer that question and ask you the second question.
Yeah. Very interesting question, and it's a common symptom actually, because even after recovery you continue to have some anxiety, and generally the first treatment or treatment choice for insomnia is a sleep hygiene, that use bed only for sleep, no tea, coffee, or any other intoxicants, maybe for 2 to 3 hours before going to bed. No stimulating kind of TV or audiovisual stimulation for 1.5 to 2 hours before sleep. Light reading, light music one can listen to. Generally, these things do help in sleep, in induction of sleep. But if these fail, then one can go for some medications. Because person after recovery from COVID would be having some anxiety. So some drugs which have also anti-anxiety properties as well as the sedative properties. One of the benzodiazepines can be taken for a short while. Could be 1 or 2 weeks or 3 weeks. That should help in sleep if sleep hygiene does not work.
Okay, and there's a second question which is also addressed to you only. How were the patient's negative thought, that is suicidal thoughts, managed in the COVID ward? This is regarding the case that was presented. That how did you manage that? Because this is from a doctor who's having a similar issue. How would you manage negative thoughts in isolation area like the COVID ward, where the classical psychiatric treatment strategy is not available that you have in your ward?
Once a person is having suicidal thoughts, then definitely a mental health assessment is required because suicidal thoughts are indicative of a underlying mental health problem, which could be depression. It could be, if it's an acute, it could be a part of acute stress reaction. And definitely a medical management is required, and we would need to, one is definitely a supportive psychotherapy, counseling, which can be done by the immediate, even the nursing staff can help, the treating doctor, the doctor who is supervising, they can help in reassurance. And in addition, we would need to start medication, because suicidal ideation is something for which risk can't be taken. A person needs to be under constant supervision. And we would need to start anti-anxiety as well as the antidepressants, and assessment by a psychiatrist is required.
Thank you very much. I have one question which is a basic question, but I'll ask that to Dr. Nikhil Tandon. Why do blood sugar levels go up in a patient who has got who is COVID-19 positive?
So I think any infection, well, the broad word is stress. So any form of stress, actually, because of increase in what are the counter-regulatory hormones, which are the hormones which antagonize the action of insulin. So whether it's catecholamines, whether it's cortisol, whether it's growth hormone, the surfeit of these counter-regulatory hormones and as a response to stress is a usual mechanism by which glucose level tend to rise in any of these situations.
So a question that is coming from Dr. Ray. There are two questions. One is any contraindications of giving proton pump inhibitors in a person who's COVID-19 positive, and is smoking a risk factor for more severe disease for people who are COVID-19 positive?
So regarding PPIs, I think the data is clear that there is no contraindication for a COVID-19 patient. Rather, patients who are severely ill, who are on oxygen, that itself is an indication for giving PPIs. So PPI is definitely not a contraindication for a COVID-19 patient. Regarding smoking, there has been some data to suggest that smoking might lead to increased chance of having COVID-19 disease, but those are again not substantiated. As I showed in my presentation, numerous studies have talked about different comorbidities and different habits, and some of these studies, they have also said that smoking might lead to increased chance of A, having COVID-19 disease, and B, more severe COVID-19 disease. But again, the data is not uniformly present in all the studies.
So I think there's no clear-cut data, but some studies suggest that you may have more severe disease if you are a smoker and develop COVID-19 infection. So I have a question for Dr. Anita Saxena, and this is, what is the role of high homocysteine level in a patient who is COVID-19 positive, and should you treat that or not?
I think high homocysteine level is a marker of, it can induce atherosclerosis. I think that we know. I don't know specifically in COVID if it has any specific a marker of severity or something. But yes, it should be treated if there are very high homocysteine levels in view of its effect on atherosclerosis.
So I agree with that. I don't think there's enough data to say that it can serve as a marker, but it is a marker of atherosclerosis per se. Question for Dr. Chadda, and this is basically based on the telemedicine guidelines. That can anti-anxiety drugs be prescribed on telemedicine for in the current era, and what is the policy as far as that is concerned?
Yeah, telemedicine guidelines say for new patients, the anti-anxiety drugs or benzodiazepine should not be prescribed. But for follow-up cases, definitely a patient who has been seen by the psychiatrist in the previous 3 months, in such cases, anti-anxiety drugs or antidepressants, any of the drugs can be prescribed, but that is also the specific medications have been specified in the telemedicine guidelines which can be prescribed. Yeah, alprazolam is a good anti-anxiety drug, but again, alprazolam is not in the list of drugs which have been listed in the telemedicine guidelines.
So I think it's very important to be clear as to prescribe the drugs which are actually listed in the guidelines. It can have a medico-legal implication, so it's important to be very careful about the prescription that you are giving. One question is there for Dr. Ray. It's regarding autoimmune. This is regarding a patient that a doctor is seeing autoimmune encephalitis. Patient is on Cellcept and now has become COVID positive. What precautions should he take, and should we decrease the mycophenolate mofetil?
So I'm not sure whether there is enough data in the population of autoimmune encephalitis, but by extrapolation from use of mycophenolate in other patients, most commonly KTP patients. So mycophenolate and other infections as such, mycophenolate is not preferred in the presence of active infection. So in the presence of active COVID-19 infection, it would probably be a good idea to stop mycophenolate, if not to decrease the dose of mycophenolate mofetil, and to start an alternative agent. So that has to be done in consultation with a neurologist. That's what.
Thank you. A question for Dr. Nikhil Tandon. Is it always necessary to start insulin in a COVID positive patient who is well controlled on oral hypoglycemic agents? That is number one. Maybe you can take that first.
No, I think there's no compulsion to start insulin. I think one has to be very clear about what are our prerequisites. The COVID should be mild. The diabetes should be, as you're saying, well controlled. There should be a predictability in terms of the meal timings. And if we are managing that, the preferred drugs are a DPP-4 inhibitor because the likelihood of hyperglycemia there is less. Metformin can be continued as long as there's no other risk factor for lactic acidosis. And the third set of agents we can try are sulfonylureas carefully because they are the ones who can cause hyperglycemia if somebody has an inconsistent diet. As long as you're meeting targets for control, which is about 140, 150 before meals, about 180 to 200 after meals, there is really no reason to insist on shifting. I think that the problem usually arises when the disease severity of COVID becomes more and the sugar spike, either on their own or because of steroid use, then virtually inevitably you need some additional insulin at that point in time. But otherwise, previously well controlled, staying controlled, there is no mandatory requirement to shift somebody to insulin.
Another question is the use of continuous glucose monitoring devices in critically ill hyperglycemic patients who are COVID-19 positive. Is there a role?
So if somebody is on a usual basal bolus, that is pre-meal boluses, post-meal bedtime basal, and you can monitor your sugars. I don't think there's, again, a need to unnecessarily institute continuous glucose monitoring. However, when a person is on an insulin infusion and you're finding it logistically difficult to, do the frequent checking that is required to sort of decide on doses of insulin, there is a role for considering continuous glucose monitoring because it sort of allows you much more scrutiny without the need of pricking the patient repeatedly. So that's the sort of scenario where I think it should be a matter discussed and proceeded with. Otherwise, in routine patients who are either on OHA or on standard basal bolus insulin, I don't think there's any specific, it's not essential to consider CGMS.
Thank you. This question has come again, it was, I think, in some form in the past also, and this is the role of anticoagulants after a patient has recovered post-COVID. What would you prefer, low molecular heparin or the Novax? Would you like to take it, ma'am?
Yeah, I think it really depends if the patient has done well and has recovered well and there's no evidence of venous thromboembolism or pulmonary embolism. I think we can stop the oral anticoagulation. But if there is any evidence of VTE, it's better to continue. Most of the people will be happier with NOACs because we don't really need to monitor much unless, of course, there is a renal problem. In that case, NOACs has to be replaced by vitamin K antagonists like warfarin or acetrom. If there is a evidence of pulmonary embolism, I think it will be good to continue for 6 months. And as long as renal function is normal, I think rivaroxaban is what we use.
Thank you very much. One question for Dr. Nikhil Tandon, and this is basically related to those individuals who are COVID-19 and have what we call stress-induced hyperglycemia. What is the chance of them developing long-term diabetes? This is the question that is coming.
It's early days, and I think what's important for us to do is be very clear, is it really stress-induced hyperglycemia or is it unmasking of a previously undiagnosed diabetes? And for that purpose, I think wherever possible an HbA1c is of great utility, because if a person comes in with an elevated HbA1c, it really means that they've had sugars which are elevated for the previous 3 months. So that parks them in a separate category. Stress hyperglycemia in most instances actually does disappear with stress, but clearly also reflects a propensity for future development of disease. We'll handle that as and when that happens. I think the more important concern with stress hyperglycemia is the implication for immediate outcome. And as we've seen, stress hyperglycemia seems to be associated with even poorer outcomes than previous disease, which has been reasonably well controlled. And therefore, early detection, aggressive management, and normalization of sugar should be our primary focus. And we'll, on follow-up, we'll figure out what happens later on.
Thank you very much. One final question to Dr. Ray before I ask all the panelists for a final take-home message. And that is basically regarding a patient who has tuberculosis, becomes COVID-19 positive, is having hemoptysis. What should we do? And is there contraindication for giving remdesivir if the patient is on rifampicin?
So I'm not exactly sure about the drug-to-drug interactions of remdesivir with rifampicin, but normally what we do is there are a number of apps available. So all you need to do is cross-check with that. So whether remdesivir has any interaction with rifampicin. As far as the management of the patient is concerned, these patients should be managed normally with antifibrinolytics, tranexamic acid. Anticoagulation should not be given, and the ATD should be continued. The other treatment for COVID-19, like steroids and other agents, they should be continued according to the merit of the case.
Thank you very much, and I'd like to thank all the panelists. We've extended our time a little bit, but I think it was important because there were some very important questions. And I'd ask all the panelists just to give their brief take-home messages, and I'll start with Dr. Deb, if what he would like to say as a take-home message from the mental illness point of view as his concluding remarks.
So thank you. Mental illness and mental stressor are a part and parcel of life, and therefore stresses will happen. Sensible things and easy things can help a long way in preventing the development of more severe mental disorders, and for that, if symptoms develop, it's the stigma should not let us suppress it. We should seek out help.
Thank you, Dr. Animesh.
So I think with as the pandemic unravels, there would be more and more cases of COVID-19 where the underlying comorbidities would play up. With the gradual unlocking, I think all those cases with all those chronic illnesses who have not been able to seek health service contact, they would be seeking health service contact. And I think there might be a surge in the number of cases due to exacerbation of the chronic comorbidities. So I think that should be taken into consideration. And finally, about asymptomatic COVID-19 with comorbidities, I think those cases should also be managed, not only from the COVID-19 point of view, but also importantly from the point of managing their underlying diseases properly. Thank you.
Thank you, Professor Chadda.
I think main message I would like to say is that maintaining good health habits, regular exercise, taking precaution of respiratory hygiene, that is using mask whenever you go out, regular sleep, maintaining a regular routine, staying away from alcohol and tobacco. These are the basic principles of maintaining good health, which would also help in adjusting to if you get COVID or dealing with the anxiety of that you may get COVID. This will help in these good health habits will keep away anxiety as well as any other serious mental health issues.
Thank you, Professor Nikhil Dandon.
Thank you, sir. So given the very clear relationship with hyperglycemia and the fact that, maybe 2 out of 3 individuals may not know they have diabetes, so they may have either previously undiagnosed disease or stress hyperglycemia, I would like to emphasize very, very strongly the need for early screening. So the first opportunity that you get, you must screen a person for sugars as soon as they go into the ward. A finger prick glucose, at least you know that they've not got hyperglycemia. If they have hyperglycemia, early initiation of therapy is important. Secondly, that you have all the options in terms of oral agents, in terms of insulin. The only sort of tailored prescription which I'd like to leave you with is on single morning doses of oral steroids. The likelihood of an increased sugar is maximum in the sort of afternoon to early evening, and therefore you will find that the dose that you require is maximally given at the lunchtime. So you may have lesser requirements at the other time points, but a pre-lunch regular dose is invariably very high, and you may need to escalate it to keep that segment under control. Also, with the steroids, you'll realize that you will need to be much more aggressive in escalation. Like increasing the dose by 2 or 3 or 4 units in a day may not suffice. You may need to be much more aggressive. Equally watchful when your patient is being tapered off steroids because the requirements come down fast. So monitoring is really the key. And the last thing, I think what really happens is, and this happens in all sort of specialist situations, the primary specialty is the focus is on the primary disorder, the focus refers on COVID, so you get a lot of detail about COVID, but the prescription sometimes misses out information on the comorbidities. So care at the time of discharge that all comorbidities are captured on the prescription and on the discharge summary, and secondly that there is a suitable advice for post-COVID fare. Most of the hospitals are now coming up with post-COVID sort of clinic creations, and I think that will again be a very important part for continuing management of these individuals.
Thank you, Professor Anita Saxena, for her final comment.
Thank you, sir. I think we do realize that cardiovascular problems do increase mortality and morbidity of COVID. So I think that's a fact that we have to remember. And I think we should advise our patients to take all the precautions in terms of social distancing, hand hygiene. In addition, they must continue to take their medicines, because I think there's a lot of issues on social media about some of the drugs not being good or being too good. I think they must continue to take what they've been prescribed, and they must keep in touch with their physician using telehealth. Of course, visit emergency in case of any problems. And I think the physicians also need to treat these patients as optimally as they would do a non-COVID or a COVID negative patient. However, with the restrictions that we have in terms of logistics and resources, etc., it is possible that we may do something which is good for the patient but may not be the best for the patient under the circumstances. The other thing is that surgery which is required for many of our patients is something that is best avoided during the pandemic, because I think there is enough data data to say that any kind of surgery increases mortality in these patients, and therefore a little less invasive approaches may be better in overall. Thank you.
Thank you very much. I think what has been highlighted in this grand round is the challenges that we are facing as far as COVID-19 is concerned, and the associated comorbidities, which lead not only to worsening of the underlying condition or severity of the disease itself, that is COVID-19, but also lead to huge challenge as far as managing these comorbidities is concerned. Classical example, of course, being of diabetes, but even if we talk of mental health issues, or we talk of cardiac illnesses, or various other disorders, as was highlighted by Dr. Ray, these are challenges that we are facing, and it's a challenging time for us because there is constant learning, and the issues of how do we manage comorbidities in a patient with COVID-19, and is this a real association, or and are they really causing harmful effects, is something that we're learning with time. But there has to be aggressive and good management, especially when it comes to diabetes, control of blood pressure, because that really helps in decreasing the morbidity and mortality. So we should be very aggressive in that. I hope this grand round has been useful, and thank you for all your comments. We look forward to having you again next week on another topic. Thank you very much.